Today we discuss pharmacological principles. Our references for this chapter are Morgan and Mikhail and a part of Paul Barash's clinical anesthesia. Pharmacokinetics generally discusses how the drug gets absorbed, distributed to the circulation, and metabolized for utilization until its excretion. We'll go through it one by one in the simplest that I can. Absorption is the process by which a drug moves from one site of administration to the bloodstream. Several routes are as follows. We will be including the topical, intravaginal, and interosseous routes. Absorption is influenced by the drug's physical characteristics, how much you give, the site of absorption, and the additives given. These additives are used to prolong the duration of the drug or to hasten its onset. Physical characteristics of the drugs includes solubility, in which a larger solubility will have a longer onset, pKa defining its pH and depends on the medium to where it will be absorbed, acidic to acidic, basic to basic. Binders stabilizes the drug if its formulation meets it. Biological membranes, as we know from the first year of college, are lipid bilayers composed of a lipophilic core in between water layers. Small lipophilic drugs pass quietly across it. Water-soluble drugs diffuse through transmembrane protein channels. Almost all except the CNS have hydrophilic channels. The blood-brain barrier prevents entry of non-specialized drugs to enter the CNS. They are composed of capillary endothelial cells with limited number of transmembrane hydrophilic channels with passive transport. This transport is limited by cerebral blood flow. Transport can be characterized by the use of energy. Active transport requires ATP as source of energy. This is also seen in elimination. Passive transport can be non-mediated simple diffusion and mediated transport via channel or carrier. We note that lipophilic drugs do not need transporters because they easily pass through the lipid bilayer. Orally administered drugs are the most convenient provided the patient is coherent and able to follow commands. It is also the safest route due to its large margin of safety. Its downside is a decrease in variable rate of bioavailability due to first pass metabolism. Non-ionized drugs are most easily absorbed. An acidic environment, such as the stomach, favors absorption of acidic drugs. Alkaline environment, like the small intestines, favors absorption of basic drugs. However, the greater surface area of the small intestines and the longer transit time allows more absorption to take place. Bioavailability is the fraction of administered dose that reaches the systemic circulation. The IV route has absolute bioavailability, meaning almost 100% is ready for utilization. A special feature of the pulmonary endothelium that can slow down the rate of IV drug absorption has been studied. This is due to varied uptake and presence of enzymes. Venous drainage of the GIT may lead to decreased bioavailability of oral drugs. The stomach and the small intestines undergo first-pass hepatic metabolism, thus decreasing bioavailability. However, sublingual and drugs absorbed in the esophagus bypass the liver in first pass, thereby an increase in bioavailability is noted. The sublingual route thus requires smaller doses of drugs to achieve therapeutic effect. Its only limitation is its small surface area for absorption. Transdermal patches provides continuous administration of drugs through intact skin, commonly used for maintenance of therapy, usually pain medications for the treatment of chronic pain. The stratum corneum is the layer of the skin which provides drug stability. The limitation is that it requires a longer time to achieve the desired effect. The picture on the right shows where the recommended areas for the patches are to be applied. This is how it looks like in real life. Per rectum drugs, commonly suppositories, partly bypasses the liver in first pass. They are administered in small children. Downside is that it may cause erratic absorption and irritation to the rectal mucosa or laceration if the caregiver is not very careful. Parenteral drugs are given via sub-Q, IM, or IV. IV drugs are immediately delivered with 100% bioavailability. Potential rapid overshoot of desired plasma concentration can be achieved, which can result in an immediate and severe onset of drugs side effects with low therapeutic index. The therapeutic index TI is the ratio of blood concentration that produces a toxic effect in 50% of the population to the blood concentration that produces a therapeutic effect. It is TD50 over ED50. Toxic dose, or TD, is a dose at which drug results in an adverse effect, while the effective dose is a dose that gives the desired effect. The therapeutic window, on the other hand, is the range between the concentration associated with the desired therapeutic effect and the concentration associated with the toxic effect. This is plotted as the area covered by the green curve. This diagram shows the interconnectivity of the therapeutic window with other concepts. The green area is the therapeutic window as shown in the previous slide. The pink area on top of the green area shows the plasma concentration at which undesired side effects appear. Plasma concentrations on the yellow area signify subtherapeutic doses. These are doses that do not achieve the desired effect. The graph also shows the behavior of the drug: a rapid rise, the peak, and the gradual decrease, provided no additional doses were given. The IM and SC routes directly are dependent on the drug formulation and the blood flow to the depot. Vicious states like high blood flow to the muscle lead to rapid and complete IM absorption. Sub-Q has a more variable absorption and onset due to its variable sub-Q flow at varying vicious states. Adverse effects includes necrosis due to irritation. The intrathecal route is made possible through injection of drugs into the spinal cord or epidural space, which later can be absorbed into the subarachnoid space. The spinal cord is the primary site of action of anesthetics. Direct injection of local anesthetics and opioids into the intrathecal space bypasses the limitations of drug absorption and drug distribution. This is a clinician's skill, which is also a limitation to its utilization. Inhalational drugs require pulmonary alveoli. Lungs have a large surface area for exchange and is accompanied with a large volume of blood flow into the pulmonary capillaries, which transports it into the circulation. Aerosolized meds approximate IV drug absorption. Examples are the inhaler and the neb for asthmatics and COPD patients, and of course, inhalational agents administered via a breathing circuit used in anesthesia. Topical agents include lotions, creams, eye drops, its corresponding ointment, and eardrops. In anesthesia, we use lidocaine creams and the emla before IV insertion or any needle puncture. Intravaginal medications are used by the OB/GYN people, while IO route is used only during CPR when no IV access is visible. Inotropes like DOPA, DOBU, and norepi can be infused along with fluids, blood products, and antibiotics. Again, the limitation to its use is the skill of the clinician. Once absorbed, drugs has to be distributed into the systemic circulation, transported through a bulk flow of blood to all the organs of the body. The relative distribution of cardiac output among organ vascular beds determine the speed at which organs are exposed to the drugs. Vessel-rich group comprising the heart, the lungs, the brain, the kidney, and endocrine glands, which receive 75 of the total cardiac output, receive the highest distribution. They are also the first to reach equilibrium with plasma drug concentrations. The amount of drug uptake by tissues and organs is limited by the blood flow they receive. Thus, the rate of drug equilibrium in the tissue is dependent on the ratio of blood flow to tissue content. Drug uptake rapidly approaches equilibrium in the highly perfused within minutes, less well perfused within hours, while poorly perfused tissue may take days. The rate of rise in drug concentration in an organ is determined by the organ's perfusion and relative drug solubility compared with blood. Equilibrium concentration in an organ depends on the relative solubility in the organ relative to blood unless the organ can metabolize it. Plasma protein binding does not affect the rate of transfer directly, but affect relative solubility of the drug in blood and tissue. High levels of binding in blood relative to tissue increase the rate of onset of drug effect because fewer molecules need to transfer into the tissue to produce an effect-free drug concentration. The more soluble the drug, the longer the time of onset and the larger the dose required. The volume of distribution is the apparent volume into which a drug is distributed. It is mathematically computed as the bolus dose over the concentration at a given time. Usually, distribution is explained in compartments. The VD is also needed to compute for the loading dose, which is the VD multiplied by the target concentration. An increase in the volume of distribution means that a larger loading dose will be required to fill up the box and achieve the same concentration. Redistribution occurs when the concentration of a drug in the brain tissue is higher than plasma concentration of a drug. In simple terms, the drug returns back into the plasma. An advantage of this is the possible reversal of the drug concentration gradient. A lipophilic drug readily diffuses back into the blood and then redistributes to the other tissues that are still taking up the drug. Redistribution more commonly occurs in muscle and fat. In summary, redistribution contributes to rapid emergence, while redistribution contributes to delayed emergence. Context-sensitive half-time is a decrement in time. This is the time required for a 50% decline in plasma drug concentration after an infusion has been stopped. The lesser the context-sensitive half-time is, the better is the drug for infusion. Distribution are usually explained using models with 1 to 2 to 3 compartments. With a one compartment model, the body is imagined as a single compartment. A drug administered distributed to the whole body instantaneously with no concentration gradients required. The concentration only starts to decrease if a drug is eliminated from the system. For the two compartment model, the first phase after injection is characterized by a rapid decrease in concentration, called as the distribution phase, caused by the passage of drug from the plasma into the tissues. The distribution phase is followed by a slower decline of the concentration secondary to drug elimination. After several distribution half-lives, the value of the first term approaches zero. A two-compartment model comprises of a central compartment and a peripheral compartment, accounting the biphasic behavior characterized previously. The rapid equilibrating compartments comprises the plasma. After an IV bolus, drug is distributed within the central compartment. The volume is in the central compartment is important because it determines the peak plasma concentration after an IV bolus injection. Example, hypovolemia reduces the volume of the central compartment. Therefore, lesser doses are necessary to achieve the desired effect. Immediately after an IV injection, Drug moves from the center to the peripheral compartment. The first order process of K12. As soon as drug appears in the peripheral compartment, some passes back into the central compartment. K21. Irreversible removal of the drug also happens in the central compartment. KE. In the three-compartment model, we imagine the body as having a central compartment, V1, the blood, a rapidly equilibrating peripheral compartment, V2, the lungs, and a slowly equilibrating peripheral compartment, V3, again, the fat and the skin. A bolus of a drug is injected into the central compartment. Drug transfer between the central compartment and more rapidly equilibrating or shallow peripheral compartment is characterized by still the first order, with K12 and K21. Transfer in and out of this more slowly equilibrating deep compartment is characterized by the rate constants, K13 and K31. As with the two-compartment model, elimination only occurs at the central compartment, K10. The volume of distribution at steady state is the ultimate volume of distribution. The drug with high aqueous solubility will remain largely within the intravascular space. An extensive tissue uptake means a large VDSS. Biotransformation is the chemical process by which a drug molecule is altered in the body for the drug's utilization. The liver is the primary organ for metabolism for most drugs, except for esters which are hydrolyzed in the plasma or tissue. The end products are inactive and water-soluble compounds which are then readily excreted in the kidneys. Phase 1 converts a parent drug into a more polar metabolite through the processes of oxidation, reduction, and hydrolysis. Phase 2 couple a parent drug or a phase 1 metabolite with an endogenous substrate to form a water-soluble compound. Hepatic clearance is the volume of blood or plasma cleared of drug per unit of time. If every molecule drug that enters the liver is metabolized, hepatic clearance is equal to hepatic blood flow. Hepatic clearance can be expressed as hepatic blood flow multiplied by the extraction ratio. The extraction ratio is the fraction of a drug removed when metabolized by the liver. The clearance of drugs efficiently removed by the liver is proportional to the hepatic blood flow. For example, propofol is metabolized almost 100%. It means that propofol has a high extraction ratio, and thus the induction of liver enzymes in its metabolism has no effect on propofol's clearance. Therefore, loss of tissue, as with cirrhosis or end-stage liver disease, has little effect on the propofol's excretion. The term for this is flow-dependent clearance. The opposite occurs with low hepatic extraction ratio drugs like methadone and alfentanil. They are slowly cleared by the liver. The rate-limiting step of these drugs is the metabolic capacity of the liver. Thus, changes in the liver blood flow have little effect on the clearance of these drugs. Renal clearance is the rate of elimination of a drug from the body by kidney excretion. It is computed by the renal blood flow multiplied by the renal extraction rate. Renal elimination of ionized and non-ionized forms depends on urinary pH. Elimination half-life is the time during which the amount of drug in the body is decreased by 50%. It may be affected by physiologic or pathologic states. This diagram summarizes how the drug goes through within the body. First, its dissolution or digestion by stomach fluids, its transit through the entirety of the GIT, its metabolism, involving enzymes and microflora and the pH of the environment it passes through, its absorption into the portal circulation, and entering the bioavailability concept, and its subsequent distribution to the different parts of the body. Finally, it also shows the excretion via the kidneys with water soluble metabolites. To help you remember, pharmacodynamics is ADME: A for absorption, D for distribution, M for metabolism, and E, elimination. Pharmacodynamics will be a lot shorter to discuss. We'll only tackle only what I think are the most relevant to our succeeding topics. Drug receptor interactions are governed by law of mass action shown in this equation. The higher the concentration of a drug or its unoccupied receptor, the greater the tendency to form drug receptor complexes. Participants for this binding are mediated by ionophores and G proteins. Ionophores are receptor-linked membrane ion channels. This too results in changes in cellular function, which ultimately result to transduction of signals and production of modified cellular behavior. Agonists are drugs that bind into receptors, making an effect. Partial agonists are drugs that are not capable of producing the maximal effect even if given at higher doses. An antagonist is a drug that binds receptors without producing any change in cellular function, while making it possible for the agonist to bind to produce a desired effect. Two types of antagonism. Competitive antagonists are reversible ones. Blocking effects can be overcome by high concentrations of an agonist, while the non competitive antagonists are irreversible. Dose response. Low doses produce little pharma effect. Small increases in dose produces a very large change. Near maximal response means a large increase in doses produces little change in a drug's effect. There are four characteristics involving pharmacodynamics. First is potency, the dose required to produce a given effect in 50% of the population, also known as the ED50. Second, the drug receptor affinity, which is the slope of the curve between 20 to 80% of the maximal effect, indicating the rate of increase in effect as dose increases. Third, efficacy, which is the maximum effect of the drug. And lastly, the population pharmacodynamic variability, or the variation of all three characteristics plotted in a single curve. This will be our final diagram. This shows the basic principles of pharmacokinetics and pharmacodynamics in general. Pharmacodynamics comprises the mechanism of action and its interactions with enzymes and receptors. And all else I leave that you understood back in pharma.